Kiran will tell us the basics of trab, how to perform a trabeculectomy right.
So trabeculectomy, perform the basics right. If you want to filter like a pro, you have to perform the basics right. So this is trabeculectomy is an old surgery that goes way back to 1968, when Dr. Keynes described the excision of Schlemm's canal along with the trabecular adnexa, and then restoring the integrity of the corneoscleral coat over the area of the excision. It's the gold standard surgery to attain low target pressures. But even in the best hands, as you can see from the primary TVT study, there are serious complications, including vision loss and research in about 8% of patients. So these are in some of the best hands. So unless you perform the basics right, you should basically try to minimize the complications in your trab. So the first step is to get a good exposure of the area of dissection. It's best achieved through a corneal traction suture. So corneal traction suture, the important thing is to get adequate depth into the cornea. If you go too deep, you can enter the chamber and deflate the chamber, after which you will have to probably fill the chamber with visco and then go ahead with the surgery. Or if you are too superficial in passing the suture through the cornea, when you pull the sutures towards the area opposite you want the area of exposure, it will cheese wire. So this is the important part of corneal traction suture. It's very good. It obtains very good vector forces and exposes a good area, and you will not end up in very rare but possible chance of a superior rectus hematoma if you are using a bridal suture. Now to conjunctival dissection. With conjunctival dissection, unlike the way our vitreoretinal colleagues handle the conjunctiva, we should be very, very gentle in trabeculectomy cases, because most of the times the conjunctiva has been mutilated already by so many anti-glaucoma medications that the patient has had. Gentle handling is very critical. At the same time, you should adequately dissect especially the subtenon space, so that you get good exposure. Now, uh, generally I use non-tooth forceps to hold the conjunctiva, and as I dissect the subtenon space and make sure that wide pockets are created on either side. This particular step of dissection is very important, not only in exposing the area of surgical dissection, but also in subsequent conjunctival closure at the end of the surgery. A good conjunctival closure basically begins with a good conjunctival dissection. You can also, as once Dr. Ebi has mentioned, mark the area of dissection with some blue, and that can actually help in subsequent closure as well. So whether you go for a fornix based or a limbal based flap, the outcomes are not considered very different in best hands. But in general, if you see the number of green lines which far outnumber the red lines, which are the advantages of fornix based flaps over limbal based flaps. The downside of fornix based flaps is essentially that you are more likely to encounter conjunctival wound leaks, especially in the context of mitomycin use. But otherwise, you generally find that fornix based flaps are faster and more technically easier, especially in deep set eyes, and also uh, the placement of releasable sutures a little more easier. Of course, with mitomycin use, various doses less than 0.1 generally has very low efficacy, and 0.4 and above tends to have higher hypotony related complications, and 0.2 milligram per ml seems to be a good middle ground. And as far as the duration is concerned, you can less than 1 minute generally has lower efficacy. Anything more than 3 minutes generally makes no difference, as the tissues are already well saturated with mitomycin by that time. 2 to 3 minutes seems to be again a good middle ground. More things about mitomycin will be discussed by subsequent speakers. So there are two ways you can use mitomycin. Either you can use sponges. If you're using sponges, it's best to use maximum 2 or maybe 3 large sponges rather than multiple small sponges. These sponges can be placed posterior to the area of dissection, making sure that the conjunctival edge does not come into contact with mitomycin. And with small sponges, sometimes you end up in a little difficulty when you try to remove the sponges. You can have these multiple small sponges getting trapped there and end up fishing for it. Also, the other option is to use an injectable mitomycin, where you inject 20 microgram subconjunctivally. Publications from both India as well as from the US have shown that this is safe and effective, compared the same as that of mitomycin sponges, and possibly gives a more controlled dosage. Now, after applying minimal cautery, you start the dissection of the scleral flap. Again, various methods. If you are making side cuts, as you notice, I have started a little 1 millimeter posterior to the limbal area. You don't want a very anterior dissection because the aqueous can get filter into those areas and can create blebs which dissect into the cornea subsequently. You can mobilize the globe with simple butts like what I am doing, or if you want a more robust stabilization, you might have to use a St. Martin's forceps on the sclera. Then through a little bit of tunneling and some dissection under direct visualization, you get a good thickness scleral flap, at least 50% thickness. Thin scleral flaps usually are a recipe for hypotony related complications in the post-op. And as you go on dissecting, make sure you dissect a little anterior to the blue-white line into the cornea slightly. And before making the scleral block dissection, I generally in almost all cases perform a very small controlled slow entry paracentesis. Now paracentesis is more important in cases like angle closure glaucomas or in cases where the pressures are very high, because a sudden decompression can result in choroidals. Also in cases like Sturge-Weber, which are notorious for choroidal bleeds. In such cases, they are especially important, but even in normal cases, it gives you better control of the anterior chamber. And post-operative phase also, for some reason, if you require AC reformation, it is easier to have a pre-existing paracentesis rather than constructing a paracentesis on a collapsed flat anterior chamber, which is very difficult. Now, cutting the scleral block, again various methods, traditionally the punch dissection, but here I am using sharp MVR blade or a sharp side port blade to make two side cuts and an angled vanas to cut the scleral block. I find this a very reproducible technique to cut the scleral block. You can basically control the dimensions very easily by this method. And subsequently you perform a peripheral iridectomy. By the time you make a scleral block, there will be slight prolapse of the iris sometimes into the wound, and with an angled vanas, you create a broad-based peripheral iridectomy. You don't want a very small iridectomy because the iris can block the ostium in the postoperative phase in very small iridectomies. Subsequently, for scleral flap closure, I generally use two interrupted sutures or either edges of the rectangular flap, and then use releasable sutures. I'll not be discussing releasable sutures because that's again a topic for discussion by another speaker subsequently. These sutures, the interrupted sutures, should not be very tight. They should allow for some filtration. You can use slip knots if you want to titrate the filtration a little. And I usually almost always use a releasable suture, one or two even, after these two interrupted sutures to reduce the risks of hypotony in the post-operative phase. Once the scleral flap is completed, you think the surgery is over, but the main part of the surgery is still remaining, which is conjunctival closure. Irrespective of the methods you use for conjunctival closure, the important is to get a watertight closure, especially in the context of onyx-based flaps and mitomycin C use. Generally, you should be able to approximate the conjunctiva very easily without much traction, as long as you've made the dissections properly in the initial phase. And the two edge anchoring sutures, I try to take a bit of the episclera as well to make sure they are well anchored on either edges. And subsequently, you can use a mattress suture or even simple interrupted sutures in the adjoining areas. Whether you want to use 10-0 nylon or 8-0 Vicryl is again left up to you, but Vicryl tends to leave a little more inflammatory changes in especially in the early post-op phase, but it's absorbable. That is the advantage. So once you do all this, small prayer and thank you. That is optional.